Winner of Apple's editor.
Examine her walk, and as you'll see, this is when she's off treatment compared to when she's on treatment. So when she's off treatment, Sadie has Parkinson's disease, so the salient features will be evident when she walks towards us. So Sadie, in your own time, can you walk towards us? And as you can see, she's got quite a flexed posture, mild hypomania or expressionless face, and there's a reduction in the arm swing, particularly on the right, but on both sides really. That's great, and if you could turn around and walk away from us again. The turns tend to take a number of steps more than is usually required, and the stride length is quite low. She doesn't actually have a tremor at the moment, so she's partially treated. And then turn around again, a few extra steps to turn, and then come on back, thanks. And the reduction in arm swing is the key thing in early Parkinson's. That's great, thanks. You can just stand there for a moment. Can you hold my hand? And there are no limitations elsewhere, so if you could rock up onto your toes. Fabulous, and down again, and onto your heels. I've got you. Great, okay, that's fine. And I'm just going to examine, you can put your feet apart a little so you don't feel too vulnerable. And you're looking for lead pipe rigidity at the elbow and cogwheel rigidity at the wrist. And Parkinson's, idiopathic Parkinson's, when it starts, is usually asymmetrical at onset. And in Sadie's case, it's more marked on the left-hand side. So I'm going to move your left-hand side if you don't mind. So at times it can be nice and free, looking for lead pipe and cogwheel, and then you perform, to exaggerate it, the Kinnear-Wilson maneuver. So if you don't mind, Sadie, if you can just lift your hand up and down, gently now, while I do this. And I should be able to bring out a little bit more lead pipe, a bit stiff at the elbow, and you can see that it's certainly much more stiff at the wrist, which is the cogwheel, which is supposed to be the lead pipe which in the elbow superimposed on the tremor that Sadie sometimes has and sometimes does not. That's great, thank you very much. Have you noticed any change in your voice since you were diagnosed? So that's hypophonia, so the pitch or the loudness of the voice goes down a bit. But swallowing is okay and everything, is it?
Yes. Provided I drink and I eat and I have to swallow something very dry.
And have you ever had any falls due to this? Falls? Well, it's one of the important red flag signs when you're trying to distinguish between Parkinson's and Parkinson's plus syndromes. You ask about autonomic features such as bladder problems, bowel problems, and swallowing problems, and also recurrent falls. Might be a red flag for Parkinson's plus syndrome.
Maybe after 10 to 15 minutes.
Okay, and after 10 minutes it starts to work and you feel what?
Well, I feel myself getting freer.
Freer.
And the second case, or finger-to-nose test. Patients with essential tremor rarely have a resting tremor, and if they do, it may be suppressed, remaining frequency.
There's 3 words. Alright, now I want you to take your right hand and tap your fingers as big and fast as you can.
On pattern motor tasks, such as finger tapping, bradykinesia is evident with decrease
Close them.
with holding hands outstretched.
Now that we have looked and got a slight idea about the patient, this now let us see the neurodegenerative diseases. Neurodegeneration is there, neurons degenerated. There is progressive neuronal loss due to this degeneration, and it can be due to oxidative stress, excitotoxicity, protein deposition, amyloid, or apoptosis. Examples are Alzheimer's, in which hippocampus cortex are involved, Parkinson's, where dopaminergic neuron loss is there, nigrostriatal pathway is involved, and Huntington's, where the GABA pathway is affected. ALS, that is amyloidosis, there is motor neuron degeneration. In multiple sclerosis, demyelination of neuron is there. And in Parkinson's disease, we have to focus first. There is decreased dopamine in the basal ganglia, and the symptoms, they appear after 80% dopamine loss. Now Now imagine the brain, specifically into the basal ganglia, where the movement is being controlled every second. And in a normal brain, you are in substantia nigra, the SNPC, substantia nigra, where dopamine neurons, they are sending signals to the striatum, and this dopamine, it will stimulate the movement by direct pathway, and it will suppress the inhibition and hence stimulate the movement by indirect pathway. As a result, there will be smooth movement, and we are talking in the normal brain. Now, if the damage begins, maybe due to aging, free radicals, genetic factors, the dopamine, the neurons, they start dying, they marta, and there is imbalance starts. A seesaw, imagine. The dopamine is less, very less, and the acetylcholine activity relatively is high, and the balance is lost. So what happens? There is circuit failure. The direct pathway, the movement promoting pathway is decreased, and the indirect pathway, the movement inhibiting pathway is reduced. So if there is and the movement inhibiting pathway is increased, that means more inhibition is there and less motion promotion is there. So as a final result, the movement is decreased, the thalamus is suppressed, and the cortex gets less excitation. Now, looking at the clinical picture of a Parkinson's patient, we see trapped pneumonia, that is tremor, pill rolling tremor is there, rigidity, akinesia, bradykinesia, postural instability. So T for tremor, R for rigidity, A for akinesia, bradykinesia. म्हणजे कोणती पण any movement to begin, there is a slower onset, okay, and there is P for postural instability. Mask faced patient is there, no arm swing as we saw in the YouTube video, and there is depression. Why it is all happening? Now in Parkinson's, there is decreased dopamine and relative acetylcholine increase, and dopamine, what it normally does is by D1 it stimulates the movement, by D2 it inhibits the indirect pathway, it lowers the movement inhibition, it increases the movement inhibition. So when dopamine is decreased, movement pathway is off and inhibitory pathway is on. So body becomes stiff, slow, tremulous, okay. Now what special toxic cause? MPTP mechanism, okay, it is important for INICET, MPTP mechanism in Parkinson's. What is that? MPTP, it enters your brain, it is converted to MPP plus by monoamine oxidase B, and it is taken, this MPP plus is taken into dopamine neurons. It will block the mitochondrial complex 1, and there will be decreased ATP and there will be neuronal death. So what we have to imagine, that brain, and inside brain some material is entering and it is converted into some other material which is taken into dopamine neurons, and when it is taken into dopamine neurons, it will block the neuron mitochondria complex something, and when it will block the dopamine, there will be reduced ATP and there will be reduced energy to the cell and there will be reduced neuronal death, and all of this is occurring in the dopamine releasing neuron. So selectively it will kill substantia nigra neurons. So there will be degeneration of pigmented neurons. The substantia nigra neurons, dopamine is less in the striatum, there are Lewy bodies present. And how do we treat this? Before treating, let us see where is the substantia nigra, where is the striatum, okay, where are the Lewy bodies. So we go to this and we see the substantia nigra and striatum and what we have to see? Yeah, that's all we have to see. This is thalamus, this striatum, putamen, lobus pallidus, caudate nucleus. This is thalamus. Wait, striatum. Nucleus accumbens. Okay. Caudate nucleus, internal capsule, putamen, lobus pallidus. This is your thalamus. Okay. This is your nucleus accumbens. ठीक है, so समोर असतं nucleus accumbens. And where is striatum? Subthalamic nucleus, thalamus, subthalamic nucleus. The caudate nucleus and the lenticular nucleus. Striatum largest subcortical structure of basal ganglia, acting as and composed of caudate nucleus and putamen, the dorsal striatum, and the ventral striatum. It includes nucleus accumbens. Okay, so the caudate nucleus. ठीक आहे, आता आहे ना anterior आली नंतर आहे ना असं गेलो ना आपण तिथे हे caudate, हे putamen असतं आणि हे caudate nucleus असतं. आणि caudate nucleus आणि putamen दोघांना मिळून आपण काय म्हणतो, striatum म्हणतो, dorsal striatum. आणि जे ventral striatum आहे ना, तर it is this particular nucleus accumbens. इंटरनल कॅप्सूलला काढून मी आणि इथे आपल्याला न्यूक्लियस accumbens दिसणार. हे आहे ऑडो, कॉडेटपासून ते लेंटिक्युलर न्यूक्लियसपर्यंत येणारे हे ऑडिओ लेंटिक्युलर ग्रे ब्रिजेस आहेत आणि आतमध्ये ग्लोबस पॅलिडस असते. सो वी हॅव सीन dorsal striatum made of caudate nucleus and putamen and the ventral striatum made of nucleus accumbens. And in Parkinson's disease, there is degeneration of dopamine-producing neurons that impair the striatum, leading to tremors and movement difficulties. So where were we? We were here. Yes. Degeneration of pigmented neurons. Substantia. Yeah, we have not seen substantia nigra. We have seen decreased dopamine in striatum. Okay. Substantia nigra बघायचं राहिलं. इथे नाही दिसणार तुला. black substance located in the midbrain, the mesencephalon. सबथॅलेमिक न्यूक्लियसच्या खाली बघितले. बघा स्ट्रायटम, कॉडेट न्यूक्लियस, प्रोटामेन, ग्लोबस पॅलिडस, देन सबथॅलेमिक न्यूक्लियस आणि सबस्टॅन्शिया नायग्रा. ठीक आहे. असं मिड ब्रेनला असं मधून कापलं ना, हे दोन बघ, पार्स कॉम्पॅक्ट आणि रेटिक्युलाटा. हे बघा मिड ब्रेनचा नाही बघ, इथून असा स्लाइस घेतलाय त्यांनी आणि अशा सबस्टॅन्शिया कॉम्पॅक्टा आणि सबस्टॅन्शिया रेटिक्युलाटा. हे ना असं जे विंग्स आहेत ना त्याचे असे, ते पुढच्या बाजूला आहे, तेवढं लक्षात ठेवा. नाईस. दिस इज आवर पॉन्स अँड दिस इज आवर मिड ब्रेन. हे थॅलॅमस आहे. थॅलॅमसच्या खाली हे असं मिड ब्रेन असतं. हे आहे रेड न्यूक्लियस, हे सबस्टॅन्शिया नायग्रा आणि सबथॅलेमिक न्यूक्लियस. नाईस. असं पूर्ण बघ असं आहे. ठीक आहे. आणि ह्याला मी आता जर एक एक ह्यातला, अरे यार काय असं हे ना असं पूर्ण पण. ठीक आहे. आणि हे दोन आता मला काय काय दिसतं इथे, इतर थॅलॅमस दिसतं आणि हे हायपोथॅलॅमस आहे. ठीक आहे. आणि मी वेंट्रल साईडमधून चालले. ठीक आहे. हे मधलं मला थर्ड वेंट्रिकल दिसतं. असं तोडत 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 गेलं. ठीक आहे. हां, आता मला कोण दिसायला लागलं. मला मिड ब्रेन मेसेन्सेफॅलॉनमध्ये रेड न्यूक्लियस, सबस्टॅन्शिया नायग्रा आणि हे दिसतं साईडमध्ये. मिड ब्रेनमध्ये गेलं. ठीक आहे. कुठून दिसतं ना, जिथून मिड ब्रेन चालू होतं ना तिथंच त्याच्या असं मला सुरू दिसतंय दिसायला. आणि आता ह्याला जर आहे ना मी स्लाइस केलं, खेळणं झालं आता त्यासोबत. आता इकडे लक्ष देतो. आपली मेन गोष्ट म्हणजे हे बॉडीज कुठे प्रेझेंट आहे बघ आणि हाऊ टू ट्रीट. आता याला ट्रीट रिस्टोर डोपामिन ॲसिटाइलकोलिक बॅलन्स करायचं आहे. लिव्होडोपा कार्बिडोपा डायरेक्ट डोपामिन का नाही द्यायचं, कारण की ते इट वोंट क्रॉस ब्लड ब्रेन बॅरियर. सो वी गिव लिव्होडोपा विच इज अ प्रीकर्सर. इट विल क्रॉस द blood brain barrier and it will convert to dopamine in the brain. Its problem is 97 to 99% it is destroyed in the periphery. So to prevent that we give those. So as a solution we add carbidopa. So peripheral dopa decarboxylase inhibitor it is, and so it will inhibit the peripheral dopa decarboxylation, and it will increase the brain's availability and it will increase the dopamine's availability to the brain. There will be less side effects. Clinical effects, it is best for bradykinesia and rigidity, less effect on tremor. Adverse effects are wearing off phenomenon. Each dose works for a shorter time. On-off phenomenon, sudden switching on, normal, off, frozen. So due to its short half-life, 1 to 2 hours. Dyskinesia is abnormal movement, chorea like due to fluctuating dopamine receptor supersensitivity. CNS effects are hallucination, delusion, sleep disturbance, schizophrenia-like symptoms. And looking at a patient, we will walk in, body bent forward, hands not swinging, small shuffling steps, and faces expressionless. Then suddenly he freezes and he can't move. That's the basal ganglia circuit failure in real time. Okay, basal ganglia circuit failure in real time. Now the Parkinson's, dopamine is gone, brakes are applied on the movement. As a treatment, we give dopamine back or mimic it, levodopa with carbidopa. And why does dopamine deficiency increase acetylcholine activity? Okay. Explain the direct versus indirect pathway in one flow. Why is levodopa always given with carbidopa? Mechanism of MPTP toxicity. Why does on-off phenomenon occur? So why does dopamine deficiency increase acetylcholine activity? In Parkinson's, the dopamine neurons, they die in substantia nigra. Dopamine reaching striatum decreases. Now normally dopamine keeps the cholinergic neurons in check. Okay, this sentence is important, that normally dopamine जे आहे ते cholinergic neuronsला त्याच्यावरती ते ताबा असतो त्यांचा, आणि त्याचा बॅलन्स ते मेंटेन करत असते. पण जेव्हा डोपामिन कमी आहे तेव्हा डोपामिनचा कोलिनर्जिक न्यूरॉनवरती असलेला जो ताबा आहे तो राहील का? तर मग ॲसिटाइलकोलिन इज नॉट इनहिबिटेड एनीमोर. सो इट रिलेटिव्ह कोलिनर्जिक ॲक्टिव्हिटी इन्क्रीजेस, हायपर ॲक्टिव्ह ॲसिटाइलकोलिन. आणि ॲसिटाइलकोलिन इट इज नॉट ॲक्च्युअली इन्क्रीज्ड इन अमाउंट, बट इट बिकम्स रिलेटिव्हली डॉमिनेट बिकॉज डोपामिन fell. And dopamine decrease, acetylcholine dominate, then there will be rigidity and tremor. So explain direct indirect pathway in one flow. Direct pathway is movement on. In cortex it will stimulate striatum, then striatum inhibits SNPR, GPM, GABA. Okay, so stimulate striatum glutamate and striatum inhibits this by GABA. Inhibition on thalamus is removed. Thalamus stimulates cortex and movement increases. So direct pathway disinhibits the thalamus, and indirect pathway movement off. Cortex मध्ये striatum inhibits GPL stops inhibiting STN activates SNPR-GPM strongly inhibits the thalamus. So cortex gets less stimulation and movement decreases. But in Parkinson's, what happens? This direct pathway is suppressed, and indirect pathway it is overactive, so movement is decreased. As a final result, there is bradykinesia and akinesia. Why dopamine always given with carbidopa? Because levodopa. Why levodopa always given with carbidopa? Because levodopa it's a precursor. If given alone, it will get destroyed in the periphery. 97 to 99% will get destroyed by dopa decarboxylase enzyme. Problem will be, very little amount will enter the blood will be seen. So if we add on the carbidopa, peripheral dopa, which is a peripheral dopa decarboxylase inhibitor, it will prevent the levodopa ka breakdown outside the brain. So more levodopa will cross the blood-brain barrier and lower dose is required, side effects are reduced. Mechanism of MPTP toxin, it's a protoxin. MAO-B will convert it into MPP plus form, and then selectively it will enter the dopamine neurons via dopamine transporter. Then it will block the mitochondrial complex 1. There will be reduced ATP production and oxidative phosphorylation will be inhibited. Dopamine neuron death will be there in the substantia nigra and Parkinson's will be developed. So MPTP, MPP plus mitochondria poison and dopamine neuron death. Why does on-off phenomenon occur? Because levodopa, it has short half-life 1 to 2 hours. So plasma dopamine fluctuates rapidly. On phase मध्ये enough dopamine, patient moves normally. Off phase drug level suddenly falls, patient becomes frozen, immobile. This sudden switching is called as on-off phenomenon. And how to reduce this? Add COMT inhibitors, the catecholamine ortho methyl transferases. Their inhibitors tolcapone and entacapone. So why tremor responds less to levodopa? And levodopa, because tremor mechanism is less clearly linked to dopamine deficiency and may involve thalamic circuitry. म्हणजे ते ना डोपामिन डेफिशियन्सी ट्रेमरचं मेकॅनिझम लिंक्ड नाही आहे.